me tient bien à cœur. Donc, on est très chanceux d'avoir avec nous aujourd'hui les deux co-directeurs de la commission Lancet sur une seule santé, la docteure Andrea Winkler et le docteur John Amuasi. Andrea Winkler est donc professeure et co-directrice du Centre pour la santé mondiale à l'Université technique de Munich. Elle est aussi directrice du Centre de santé mondiale à l'Université de Oslo. Et on a aussi John Amuasi, donc le co-directeur de la commission Lancet, qui est aussi professeur au Ghana à l'Université des sciences et des technologies Kwame Nkrumah. J'ai probablement massacré le nom, vous m'en excuserez. Donc, John et Andrea vont nous parler de cette initiative de la commission Une seule santé du Lancet sur laquelle ils travaillent depuis un bon 2 ans maintenant. Donc, je vous laisse. Andrea va commencer. C'est donc vraiment un grand plaisir. Puis je suis vraiment contente qu'ils aient accepté de faire ça pour nous, de laisser Andrea nous parler. Elle va nous parler en anglais, mais vous pouvez poser les questions en français. Andrea comprend très bien le français, mais pour présenter, c'est un peu plus facile en anglais. Donc, je me cache et je laisse la parole à Andrea.
Merci beaucoup, Hélène. C'est un grand plaisir. Et comme tu as dit, je comprends bien le français, mais pour les termes techniques, ça va beaucoup mieux en anglais. C'est pour ça que je vais faire la transition maintenant. Et je vais commencer à parler en anglais. Mais après, n'hésitez pas et posez vos questions en français. So thanks again very much, Hélène and team. And I'm very pleased also that my colleague and friend and the co-chair, so we are both co-chairs of the Lancet One Health Commission, is also with us today. And I have the privilege to start to give you an overview on the Lancet Commission, on other related activities, and on most recent activities. And then John will take over and give you more practical examples of One Health approaches. And I would assume that this is from the African context. So, I mean, this is a wonderful slide. And it just shows to all of us how nice it could be if we were really abiding by nature's laws and various concepts that we try to disentangle for you now in the next 30 or 40 minutes. So humans, animals, and the ecosystems or nature, we are all connected by default, and hence the health of humans, animals, plants, and the ecosystem are interdependent. This connection has always been, but somehow along the line, we seem to have lost this connection. The last centuries have been those of profound impact of humankind. And it has produced lots of problems: pollutions, climate change, destruction of forests, impingement on biodiversity, cruelty towards animals, etc., etc. And everything has culminated, of course, all of you know, is the COVID-19 pandemic. And most likely, it could have been prevented if a One Health approach had been applied and implemented consistently at different levels. But that is only speculation. At least now we know what can happen if we don't, if we're just ignorant about nature's laws and our interconnectedness with nature, animals, plants. Hence, the COVID-19 pandemic has underscored the urgent need for a recalibration of the human, animal, and environment interface. And this is what we are trying to put forward in the Lancet One Health Commission. So we define One Health as an integrated approach to advancing multi-species health, again, at the human, animal, and environment interface. What are our aims? And I will come to the circle on the right side, and John will pick it up again and will underpin it with practical examples. So first of all, and it's not that easy, it's just actually one sentence, but to produce the evidence synthesis for the added value or for value for a One Health approach. And we have been now doing this for 1.5 years, of course, being sidetracked by the pandemic. But there is a lot of evidence, but there are also lots of gaps. And for One Health, everybody is an expert. And in fact, nobody is. Then we would like to also identify relevant stakeholders, and they may have actually changed now through the pandemic, and disentangle motivating factors for the stakeholders' participation. We then, at the very last part of the commission report, we're going to produce policy recommendations and hopefully underpin those recommendations with an investment framework. And that framework also changes throughout now COVID-19, the pandemic. I was very happy to receive a last-minute message today from one of our commissioners who is working at the World Bank and enlightening me about new financing possibilities that so far I didn't know about. Anyway, what I want to say is that things are really in motion, and what John also told me the other day. So basically, what will be the output? I mean, if we are too progressive in our Lancet One Health Commission report, then what we say will not be valid anymore in a year's time. And if we are too conservative, we may just miss the train. So it's quite difficult to conceive a One Health Commission during those times, but it's also a real chance to tell the world what science thinks should be the right path. Anyway, there are various frameworks how One Health could be perceived. Not the least, the Sustainable Development Goals, the universal health coverage, recent evidence underpinned principles like the NEO principles, but also our own principles that actually we have come up with during our very first meeting when we're still able to meet in Oslo for the inception meeting in May 2019. And we have come up with this circle, and of course that can always be adjusted and changed, but just to make the case and to show you what we're going to work on. So one focus will be shared environment. So humans are not at the center, they are part of a circle. Animals, plants, wildlife, agriculture and aquaculture. And we're going to look at this, or we have already looked at it, through the infectious disease lens, but also the non-communicable disease lens, and then the antimicrobial resistant lens. And I shall mention here that Hélène Carabin is actually leading together with colleagues, but she was the main lead of that working group. Then we have another working group on shared medicines and intervention. Again, the same principle, and safe food and food systems. For sure, we may have left out important issues like, for example, urban health. But it's only so much we can do in 25,000 words, and we will never be able to be absolutely super comprehensive. And then the outer circle could be somewhat of a framework. Important issues, maybe avenues or implementers that could be used by institutions, like the systems approach, surveillance, which is now really big, integrated digital health, prediction, knowledge integration, leadership, governance, good governance. With all the new initiatives, I think we have a serious problem of governance, One Health governance, and of course, gender, community, equity, and ethics should be at the heart of such a commission, and not the least, partnership. So this is the commission. John and I have been doing this together, and then we have 20 outstanding experts in various fields that have been pretty busy now during the pandemic, as you may imagine. We have 2 secretariats, actually. One is in Oslo, the University of Oslo, and the other co-secretariat, again, we're doing this together, is with John's institution at the Kumasi Center for Collaborative Research in Tropical Medicine, or short KCCR, at KNUS, the Kwame Nkrumah University of Science and Technology. So I hope I pronounced that okay. And all of that is supported. So those 2 secretariats are supported by the Center for Global Health at the Technical University of Munich in Germany. It's a bit of a complicated construct, and we still are optimistic that we're going to reach our messages by consensus. At times, as you may imagine, there are different opinions, and consensus reaching is a challenge. This was the official announcement in May last year, together with Tamara Lucas and Richard Horton, the editor-in-chief of the Lancet One Health Commission, and Tamara is our contact editor at the Lancet. We are quite active, and we have been quite active. We have really tried to harness the pandemic's positive side. So we've done quite a few digital events. We have been present now for the 2nd time at the World Health Summit, where we engage also in highly political discourse. We had this year a panel on pandemics and operationalizing One Health, and also one on climate change and One Health. For the Lancet One Health Commission, it has always been important really to reach out and not to create a new silo through One Health, but reach out to like-minded concepts such as planetary health. And we can discuss that if you're interested later on. We have also been, of course, intrigued by the COVID-19 pandemic, and we knew that we have to catch that very moment and also turn it into an outlet of the Lancet One Health Commission, and we dubbed it the COVID-19 One Health Research Coalition. Again, Hélène Carabin is part of the 7 founding members. That coalition is still in a conceptual stage, and we are quite certain that it will be active once we have put together the messages of the report. And the key aims of such coalition is really to be very inclusive and to bring people on board. It's open for expressions of interest, so all of you can be part if you want to contribute to the One Health agenda. The sub-aims or the specific aims are to enact the key messages of the report, as I just said, to stimulate and contribute to the research beyond the scope of the report. So we will have so many open gaps, and we hope we can address those through the coalition, and then to engage in scientifically and politically instrumental capacity within the paradigm shift now of One Health through the COVID-19 pandemic. So that's another outlet of the Lancet One Health Commission. Here are a couple of webinars, topics that you're all familiar with, and you can, I'm happy to share my presentation, just by the way, because you can listen to the webinars if you're interested later on. They're all on YouTube files. So one is on One Health and the COVID-19 pandemic. That was our first one. I think that's pretty obvious. Then comparing the pandemics and lessons learned, how to develop a career in One Health and education and capacity building. This slide is really to show you that we are not, although One Health is really infectious disease, pandemic, emerging disease focused right now. The Lancet One Health Commission is extremely keen on broadening this concept, broadening the concept within infectious diseases, so not only focusing on those emerging diseases, but also remaining with the neglected tropical diseases and moving forward their elimination agenda. as an example. But we are also very keen to really have the non-communicable diseases on board, as there's a broad One Health agenda within non-communicable diseases as well. And as I'm a neurologist by training, I've just brought you this example where we have launched yet another coalition to the COVID-19 agenda and also being inspired by COVID-19. And that one is fully functional and highly productive. And we're working very closely with the WHO Brain Health Unit. Basically, we are trying to harness and synthesize the evidence, whereas the WHO Brain Health Unit is working more on the technical side. And it has really worked out well so far. Now, for the last 5 minutes, I would like to introduce something that I quite like, but is also most likely disputable. So should One Health become the new norm? We feel that many institutions, governance, agencies think that it should, but how sustainable is this? Are many agencies, governance, organizations just acting on the spur of the moment? And I thought, because that is also quite hot off the press information to me, I will just run a couple of initiatives past you before I hand over to John. And please forgive that slide. That's the most text-busy slide ever. But I think it's important to see what that initiative is up to. So that is the One Health high-level expert panel. And it has been born out of the tripartite initiative. The tripartite is WHO, FAO, and OIE together, and it was there before COVID-19. There was a huge agenda on One Health before COVID-19. But they have now used that energy and also invited in UNEP, which is the United Nations Environmental Program. And the environmental side usually falls short in that overarching One Health concept. So that is really a big achievement. So it's no longer a tripartite. There will be 4 partners most likely, but it's still, everything is in the progress of negotiation. What are they up to? What is their aim? So that new construct of One Health high-level expert panel has been announced by France and Germany during the Paris Peace Forum in 2020. And I'm quite proud that my government, so I'm based in Germany, is part of that. So it was very surprising to me when I read it today that actually there's a lot of emphasis on science. And I think if you take something away from this, take away that WHO, FAO, OIE, and UNEP, they're really interested in the science bit of One Health. It hasn't always been like this, that WHO and other agencies have been interested in science. So to provide advice on the analysis of scientific evidence of the linkage of the various healths, human, animal, environmental, have an emphasis on food systems, but also ecological and environmental factors contributing to zoonotic diseases, but also to their emergence, but not only. They take a broader approach. Neglected tropical diseases are important as well. And the spillover is a key word there. They want to contribute to the One Health research agenda setting. And that was really interesting to me. And we'll see how that's going to flesh out. And they want to have a say in One Health policy response in the countries themselves and act on other emergency issues that may crop up with regards to One Health. That's one thing. I think that's most like the most influential initiative so far. I don't want to miss mentioning the Berlin principles that John and myself were invited to, and they have been actually kicked off by the Wildlife Conservation Society, represented by Chris Walser and Kim Grützmacher, the first and the last author. And they have been a follow-up of the Manhattan Principles, where One Health, together with conservation and biodiversity, human-animal health, was coined in a proper scientific release Some say for the first time. That may be disputed. But that's a follow-on on the Manhattan Principles, and they have been launched at the end of 2019, so before the COVID-19 pandemic, in Germany, within a forum called One Planet, One Health, that John and I were also invited to. It was a very nice launch within the German Federal Ministry of Foreign Affairs. And I just want to point out this here, which says the urgent call for action, I beg your pardon, that was one too far, an urgent call for action for cooperative, multilateral, democratic engagement at all levels of society. So the One Health construct should really permeate through various levels and also be a political agenda. This is what one of the output of those principles were. And I'm quite happy to say that this is the German foreign minister, and during the Paris Peace Week, he has actually quoted the Berlin Principles and has quoted them as a stepping stone for the big tripartite initiative. And I think this was really nice to see what science and also policy briefs, what difference they can make and how they can shape, if they're released at the right time, the political agenda. So in the run-up now to the G7 and G20, just to let you know that there are also One Health activities going on. For example, the UK was quite keen on the One Health Intelligence Hub in collaboration with the tripartite high-level council. It was named before. Now it's an expert council. It will not be a tripartite anymore, as I just said, because UNEP is also on board. And then this is quite interesting. Italy is also gearing up for the G20. The concept of One Health will be there, but hasn't been released. It's still quite conceptual. But what our colleague from the World Bank told us today, that there will be a high-level independent panel on financing the global commons for pandemic preparedness and responses. And there will be quite a bit of financing behind that. So give the commons, the common space that nobody of us owns, basically, a voice in that pandemic preparedness, and back it up by, I would say, quite substantial financing. And the last, so I'm almost done. That is the last thing. That is basically, we cannot follow it anymore, because as we speak, new initiatives are springing up. So these are just a couple of government, agency, organization-specific initiatives that are currently being announced, and resources are mobilized. So FAO wants to create a Center for Zoonosis and Food Safety. Then the International Atomic Energy Agency has put forward a network called Zodiac. Then the French a couple of research organizations in France have put forward the Pre-Zode network, which I'm gonna show you a picture of. And OIE wants to establish a wildlife health management framework. The German Ministry of Economic Cooperation and Development has already last year launched a One Health research center in Kenya, and backed it by a quite substantial funding. So that is the Zodiac and the International Atomic Energy Agency. And I found that here quite interesting. They said, well, we have the technical, scientific, and laboratory capacity, and we now really want to be helpful in that crisis. So we make our facilities available. Pre-Zode, Preventing Zoonotic Disease Emergence, is a large French network, also in cooperation with the Germans. So it has been launched by the Lancet, and officially it has been committed to at the One Planet Summit. basically by those three French research institutes, the INR, AE, CIRAT, and IRD, that are within the development agenda and agricultural agenda in France, actually. They claim they're the first ever international initiative to prevent future pandemics. I'm not so sure, but they're certainly among the first. So that is the German Minister of Economic Cooperation and Development, who has announced the creation of a new One Health priority very early on already in the pandemic. And that's my last slide, where the contract was signed for the new One Health initiative for Africa. And that center is already up and running and basically already implemented. And we are hoping to be able to embark on some research projects in the near future with them. So without further ado, and I think I've actually overused my time almost, I would like to hand over to John to concretize our endeavors a little bit more. Et je vous remercie beaucoup pour votre attention. Merci beaucoup.
OK, merci beaucoup, Andrea. Hélène, est-ce que je commence ou j'attends un peu?
Non, vas-y, tu peux commencer. Tu peux partager ton écran.
Merci, merci. Oui, contrairement à Andrea, la compréhension du français n'est pas si excellent. Aussi, parler français, j'ai pris beaucoup à parler. Donc, comme Andrea, je vais présenter en anglais et puis je vais répondre à quelques questions aussi, peut-être en français, je ne sais pas, ça dépend de comment les choses vont aller. Je voudrais dire un grand merci à Andrea pour sa présentation, c'était vraiment excellent. Moi-même, j'ai appris beaucoup et je voudrais demander si je peux avoir la présentation après. OK, donc je vais présenter une case study de One Health au Ghana qui peut-être est applicable à des autres pays LMIC, comme on dit, LMIC. Je vais partager mon écran. OK. Est-ce que vous pouvez confirmer si vous pouvez voir?
On voit ton écran, c'est bon.
Merci, merci. OK. Donc, Rabies, case study of One Health in Ghana and other LMICs. I think rabies is a really important example to share the complexity that is inherent in One Health. And for a couple of reasons. One, because of rabies as a very unique disease, perhaps your classic zoonotic disease, but a zoonotic disease that impacts an animal which is very dear to humans. The dog, of course, rabies is also seen in raccoon dogs and other canines, which may be of less interest to man from a friendship perspective. But rabies is also one of the 2021, however I like to call it, neglected tropical diseases recognized by the WHO. It is an infectious disease for that matter. So it really ticks all the boxes in that regard. It is a disease of poverty, which is perhaps the more interesting thing here. Very important NTDs, rabies within the NTD space that goes beyond the disease in itself, because the agent here, in this case, the dog, also could be a very important agent or reservoir for another critical NTD, which we are at the cusp, I should say, of eliminating, if not actually eradicating. I just use the word eradicating, which is guinea worm. And there are recent reports, well, I shouldn't say recent, but over the past couple of years, reports of the potential resurgence of guinea worm in human beings on account of canine guinea worm. So when you think of the dogs and relationship to human beings, even beyond rabies, and within the NTD space, your mind also goes to guinea worm. You can also think of others like ringworm, hookworm, roundworm, salmonellosis, Lyme disease, tapeworm, etc. All these have very important canine implications. And when you look at the relationship between humans and canines, then you begin to appreciate how important dogs are, and in particular, what rabies really means, and the thoughts around rabies control. The thing about rabies in itself is the fact that it's a bit difficult to diagnose, especially in low middle income country settings. It is a viral disease. And so typical healthcare centers or settings are not in a position to make a definitive diagnosis of rabies except via clinical signs and symptoms. And for that matter, if you are showing overt signs and symptoms of rabies, then you are essentially on your way to the grave. As the WHO puts it, once the clinical symptoms appear, it is virtually 100% fatal. And I must say that when you talk about dogs and the guinea worm in Chad, it is very clear that guinea worm did resurface after 10 years of elimination, did resurface in dogs. And then the concern is that there's a real concern that they could pass on to human beings. So you want to think also about the close relationship between man and dog, and the fact that almost all rabies cases are dog mediated. So yes, you can find rabies virus in vampire bats. You can find them in raccoon dogs and in other canines of interest. But when you speak of the disease rabies, really your mind goes to dogs, and the man's friend, the dog. And so what we call is a tragic story of man's best friend, and the relevance of dogs, either for therapy, emotional support, for service, cannot be underestimated globally, perhaps less so in my part of the world. But you know, a lot of people do identify with dogs. You know, I have a nice dog at home. She's called Lola. I don't have a picture today, but if you do visit me in my part of the world, you'll be welcome to see Lola. So given the kind of relationship that human beings have with dogs, and I could go on and on with this, it's very easy to pick up rabies, especially if the dog has not been vaccinated. And ask me how many people in LMICs focus on the vaccination of their dogs, and how much enforcement, if any at all, is there regarding the vaccination of dogs against rabies. So the risk is real, especially in societies where dogs are allowed to roam freely and therefore can easily pick up the virus and transmit it to human beings. Of course, for dogs that are confined to various spaces within a compound, that will be different as opposed to dogs that could, you know, move around freely and pick this up from other places. I already mentioned the inherent complexity in diagnosing rabies because of the incubation period. You're looking at 9 to 90 days. That's how we're often taught, but in reality, it's about 2 to 3 months. Sometimes it can be 1 week and even up to a year in some cases for rabies to actually overtly manifest. So how do you even link the history of a dog bite, if you're able to elicit that history at all, to the demonstration of the clinical signs and symptoms of rabies? The symptoms are very unspecific. Could present from anything like fever and chills and even coughing through to symptoms that may be synonymous with mental health disorders. There's no human ante-mortem test to date, and a huge disparity between dog bites and rabies, and the linkage between the two. More important, in developing countries or LMICs, dogs' vaccination history is very difficult to trace. Stray dogs are a huge issue in many African cities, towns, and villages. It is really a common sight. I do remember even when I was driving to work this morning, I almost knocked down a pack of stray dogs just exiting my junction. And this is not an uncommon sight at all. Available post-exposure prophylaxis is a huge issue. The anti-rabies vaccine, that's even how useful it is post a bite, and how that is stored. That's what I mean by how useful it is. And what that means for its effectiveness is another question. The amount of environmental or community surveillance that should go into being able to prevent rabies, and the inherent interdisciplinary approaches which are necessary for effective rabies control, which is what I will come to in trying to present this as a classic One Health issue. Ask me, what is the true burden of rabies? Do we know this at all? It's almost 60,000 deaths annually in 150 countries. That's the estimate that we have. Almost all the cases are in Africa and Asia, because dog-mediated rabies has essentially been eliminated in the West, in Canada and the US, in Japan, and in a couple of Latin American countries. Looking at upwards of 20,000 plus deaths in Africa on account of rabies. Almost all these cases are dog-mediated. I already mentioned that already. And there's a huge socioeconomic gradient involved here. Almost all the cases are among the rural poor. We can obviously tell why this would be the case. Not only the risk of a dog bite being higher, but also the risk of not going for post-exposure prophylaxis or not having the access to it, or its availability is more likely among people of the lower socioeconomic quintiles. The sad thing about this is almost half the cases are in children under 5, and that's a really important consideration. But just the paucity of data on rabies in LMICs is perhaps what is of greatest concern. More specifically, where I sit here in Ghana in West Africa, is just the data that exists on rabies is so scanty, but there is enough to show that it is a clear and present disease. I'm yet to see any recent data on surveillance among canines or stray dogs, for that matter, in Ghana, the prevalence of rabies. And this would certainly be an interesting proposition. But about 123 clinically confirmed human rabies cases, and this is confirmed via viral isolation, being really a conclusive cases of rabies. Dog bite to rabies ratio is 3:1,000. The reality is most likely to be very different. And these concerns about rabies in Ghana did meet with the WHO's interest, and in a 2019 publication, they did mention a spread of canine rabies sparks broad community response in a Ghanaian town, and this was an interesting article that was mentioned by the WHO in Ghana. So in rabies, there are gaps to fill, important gaps. I've already spoken to most of them, so I will not spend a lot of time on these points, except to point out the disconnect between medical and veterinary services when it comes to addressing the problem of rabies. And I think this is where the rubber hits the road when you begin to think of One Health approaches and how things really need to change, not only in Ghana and other LMICs, but globally, when we think of diseases that are zoonotic in nature, especially. So think about the two major silos. The one on my left is the Ministry of Agriculture, which interestingly houses or has direct supervision over the Veterinary Services Department. And so there's a complete disconnect between the Ministry of Agriculture and the Ministry of Health, very huge disconnect, whereas the Ministry of Health would have direct oversight over the Ghana Health Service and the NTD program. Now, rabies is considered a neglected tropical disease. It's an infectious disease. It's a zoonosis. So it would fit under this silo to my right, but it also really fits in the silo to the left because it's a disease with which affects actually the dogs, and it also the dogs serve as the
Oups, je pense qu'on vient de perdre
for,
John. Ah, voilà.
for rabies of agriculture. Oh, excuse-moi, Hélène, est-ce que vous pouvez m'entendre?
Oui, oui, là, ça va, c'est bon. C'est
Ok,
dégelé.
merci.
Vas-y,
Désolé.
continue.
S'il vous plaît, dis-moi s'il y a un problème. Normalement, l'Internet, c'est pas vraiment.
Non, ça va, c'est bon, c'est reparti. Vas-y.
Merci. Ok, je continue. Donc, with the Ministry of Agriculture, we'll take care of the veterinary services. There's this huge disconnect between the two. The question would be that who should be responsible for addressing rabies? Rabies control and elimination is essentially focused on the canines, the dogs. So the Ministry of Health will tell you that this is no business of ours. The Ministry of Agriculture and through the Veterinary Services Department is going to complain that, well, if we address the issue of rabies in dogs or address a stray dog issue or the dog vaccination issue, the real benefits would accrue to the Ministry of Health. So who should do the work for who to take the glory or to take the praise? And then this becomes a classic case of siloed approaches, siloed thinking, and a complete disconnect between two ministries where really it should be a classic case of interconnectedness and a One Health approach towards addressing the problem. So this is where we bring in our concept of One Health, which is by no means a perfect concept. And Andrea introduced this beautifully. And if you look at that outer circle, this outer circle contains what we call avenues for doing One Health, or avenues for through which we hope to operationalize One Health. So each of those portions of that outer ring we can look at in relation to rabies very specifically. I don't want to go into the individual or the smaller circles because Andrea already spoke to these, but for this particular example, I want to focus on these avenues through which we can do One Health more effectively. So this is just about my last slide, I must say. You want to think about integrated digital health evidence and prediction. Well, for that, you obviously would need certain inputs, which would come through an integrated health systems and surveillance system. Now, how much surveillance is going on within the Veterinary Services Department? How is that linked to the Ghana Health Service or the Ministry of Health surveillance systems? We do have the District Health Information Management Systems, the DIMS, which interestingly was developed at the University of Oslo and now is sort of the go-to health surveillance system globally in many LMICs in Africa and also in Asia. But this system only addresses human health. It will capture for you dog bite, would capture for you rabies, but very scanty information because of the challenges in diagnosis. Whereas the real problem with rabies would be the dogs, but this is totally disconnected and separate from whatever surveillance system would be run by the Veterinary Services Department. So how do we go about integrating this evidence and use that for predictive purposes? We already know about the hypothesis of COVID having originated in or spread to humans, from animals to humans via the horseshoe bat, perhaps. And this is a very high level, I should say, hypothesis. The recent evidence coming out of China might suggest that it may have actually arrived in China via some frozen fish from elsewhere. These are some of the arguments that are being put forward, but I cannot tell if we would ever come to a conclusion on that. You will want to think about issues around gender disparities, age disparities. I already mentioned that over half of the cases of rabies, maybe not to overestimate, actually about half of the cases of rabies are actually found in children under 15. Is there a gender gradient in there? What does that mean for how we go about addressing integrated surveillance systems? I already mentioned that there is a socioeconomic gradient, very clear socioeconomic gradient when it comes to rabies, and that is why we do have NTDs, neglected tropical diseases. The heart of it is really the poverty, and those who are neglected, who don't have a voice to complain, who are essentially invisible because of their the socioeconomic status, invisible to your health systems, your surveillance systems, and these really pose challenges. What are the policies, the legislation, the governance systems around these? And because of time, I'll just rush through the rest. What is the investment case? And perhaps this is the most interesting part of the outer circle in specific relation to this rabies examples. What would be the investment case for the Ministry of Agriculture working in together with the Ministry of Health on the rabies issue, the challenge of who puts in the money and who reaps the benefits? How do we cross, or how do we fill this gap? How do we bridge this silo? And a number of people have proposed various ways of doing things and different metrics for measuring the success of these ministries. And these ministries have very clear indices, which they are assessed by the central government. And nobody wants to put in something for the benefit to accrue to a different ministry. And of course, knowledge and integration and leadership. It would take a Minister of Health who has a clear understanding of what this means and the equity issues around the need to work together with the Ministry of Agriculture. Would the Ministry of Health be willing to have a budget which will be dedicated to actions which will not necessarily be undertaken by the Ministry of Health, but maybe the Ministry of Agriculture through the Veterinary Services Department? Is there a need for a complete overhaul of the setup of the ministries and push the Veterinary Services Department under the Ministry of Health rather than the Ministry of Agriculture? One may say yes is the way to go, by the argument that it risks further siloing these activities, because then now you have the Vet Services Department firmly under a Ministry of Health, and then there's even less of a reason for a more trans or interdisciplinary approach between Ministry of Health and Ministry of Agriculture. It doesn't solve the issue of the wildlife and other zoonoses emerging and re-emerging infectious diseases, which would fall very clearly still under the ambit of the Ministry of Agriculture. Of course, you want to think about your Ministry of Trade and Tourism, which would be concerned with the human-wildlife interface and the risk for transmission of disease and so on. So you can never really run away from the need for a One Health approach, and simply restructuring ministries and moving blocks of departments under different ministries will not be the solution to the problem. But just recognizing perhaps every single one of these, our proposed outer circle elements within all the implicated ministries, and using those tags to clearly identify what are interlinkages, and sharing budgets, which are not necessarily ministry-centric, but more avenue or agenda-centric, like, say, integrated health systems and surveillance would be where the budget would fit. And then we try and identify which ministry will be responsible for a specific aspect of this, rather than saying health system surveillance is for the Ministry of Health and so on. Well, I've spoken for a long time, donc je vais arrêter ici. Je vous remercie pour votre attention et je suis ouvert pour les questions. Merci.
Je vous remercie vraiment beaucoup à tous les deux d'avoir pris le temps de nous parler de
excusez-moi, j'ai oublié quelque chose, s'il vous plaît. Je vous remercie mon collègue Melvin Aboubaté, il est en ligne. Il m'a vraiment assisté à préparer les diapos. Donc, Melvin, grand merci à toi.
Merci, Melvin. OK, je pense qu'on a une question. Je ne sais pas qui l'a posée, mais c'est venu sur Twitter. La question est en anglais. Je vais donc la lire en anglais. What is the appetite for shared budgets among ministries to address this very important question for breaking the silo approach? Donc, je vais la traduire en français aussi. Donc, quel est le désir d'avoir des budgets communs entre les ministères pour effectivement essayer de briser ces silos entre ceux-ci?
Oui, je voudrais qu'Andrea commence parce que nous avons fait une table ronde en Allemagne l'année passée, non, il y a 2 ans. Et je me rappelle qu'il y avait une représentative de Beringer, je me rappelle bien exactement la compagnie. Il a donné un bon exemple de comment ça marche. Donc, Andrea, je ne sais pas si vous pouvez commenter sur cela.
Yeah, thank you, John. And thanks, Hélène. Merci beaucoup. Well, from the German side, I can say that Germany has been a global, so, you know, also maybe to take one step back, One Health also needs to be situated in the global health agenda. I mean, One Health can be at different levels. It can be super local. One Health can be just at a single farm. And as we have learned and still learning as we go, One Health can actually decide where we are going in the very big picture. So where does One Health come? Which initiative does it come under? And global health has been really important to the German government. So Angela Merkel, our chancellor, she has used global health as one of her top priority while she's in office. So she has leveraged a lot of finances, a lot of activities and action. She has actually launched together with the then president of Ghana and the prime minister of Norway, the global action plan behind Sustainable Development Goal 3, et cetera, et cetera. And she has already always hinted at this multi and interdisciplinary approach that, of course, is the core of a One Health approach. So what I want to say here is that the German government is pretty ready, but still there are the old entrenched structures that need to be overcome. And as John, I think you have really mentioned this beautifully and shown it beautifully. If flexible funding is provided, then a One Health agenda or even a global health agenda is more likely to be taken up. So I cannot comment on that's internal knowledge on the financing structure for global health within each and every German ministry, but clearly the Ministry of Education and Research, the Ministry of Education and Research, but also the Ministry of Economic Cooperation and Development, especially the latter, are at the forefront of One Health. So within Germany, you can, at least I realized in my engagement that 1 to 2, the Ministry now of Health is also following, they're getting interested. For sure, they have their own global health resort or department, very active. But especially the Ministry of Economic Cooperation and Development, they have acted on the spur of the moment, but the One Health principle was already part of their discussions and their narrative before. But they have launched that One Health Center together with the Kenyan colleagues and others almost overnight. So they have been fast in mobilizing funds, but again, that was from one ministry. I stop here, and because I also am mindful of time, I can just say that Germany is more than willing, but of course the structures need to be in place, and that is not always visible to an outsider. Some ministries are taking more the lead. What is visible within Germany, and I think this is quite often the case, the Ministry of Agriculture very often is not at the table. And this is now in Germany, the Ministry of Agriculture, they're also getting more and more interested, but with a delay compared to other ministries. Thank you. John, maybe over to you because, there's even a second question. So back over to Hélène.
Yes.
John, voulais-tu ajouter à ce que Andrea a dit à propos de la question sur les silos de financement? Et peut-être je vais ajouter la sous-question à ce qui dit quelle serait l'ouverture des gouvernements d'avoir comme concept porteur la santé pour avancer les politiques et puis les décisions gouvernementales. Mais donc, c'est Lisa Méry qui a posé cette question-là. Lisa, une sous-question à toi. Quand tu dis santé, tu veux dire santé humaine? Parce que dans mon monde, à moi, santé, ça veut dire toutes sortes de choses. Mais
oui, dans le fond, c'est les deux, juste l'idée de la santé de la population, mais la santé aussi de, tu sais, là, l'exemple qui était présenté, la santé des chiens, il y a un impact sur la santé des humains. Mais jusqu'à quel point est-ce que les gouvernements sont ouverts à, tu sais, on parlait de la partage des budgets, mais est-ce qu'il y a même un intérêt de faire des décisions au niveau des gouvernements et des politiques qui vont se baser sur l'idée d'avoir une meilleure santé populationnelle
pour tous.
Oui, pour tous.
Merci. I think that there is huge opportunity, but also a massive gap. I can give an example of Ghana, which does apply to several other countries in Africa, where we have the Ministry of Agriculture. Now, it's not just agriculture, it's actually Ministry of Food and Agriculture, which is really interesting. And then you have the Ministry of, I think it's Wildlife and Tourism, if I'm right. And then you have your Ministry of Health. The appetite for shared budgets at this stage is very low. The reason is ministries want budgets for themselves. They are judged based on how they utilize those budgets and the outputs of those budgets. And those are translated into political, currency and used to demonstrate whatever the government has been able to do. Rather unfortunately, most of the indices in my part of the world of success are physical infrastructure. How many clinics did we build? How many hospitals did we build? You hardly hear them talking about, how many lives did we save from, it's all about, it's very hard that pushing that concept of what did we stop from happening? It's always what do we do? And this is a big challenge, specifically for shared budgets with regard to the example I gave, almost non-existent. And this is why I'm very excited about some of the things that Andrea talked about. All these very high-level initiatives to push the One Health agenda are very critical, especially at the LMIC level, because most of the budgets for the Ministry of Health, Ministry of Food and Agriculture, a good chunk of those budgets actually come from donor funds, or what they call them, development partners, exactly. So if the development partners have rules or have conditions attached to the funds that come, constraining ministries of health, ministries of food and agriculture, and so on, to work together on certain topics. Otherwise, they're not getting the money, or the utilization of these funds and further funding is tied to results which are One Health inclined. It could make a huge difference. Then if the government itself, which is signing up to some of these high-level treaties or agreements, which hopefully will come very soon, given the level at which things are going, it could then further constrain the government to restructure the way in which ministries work together. Of course, we do have the Abuja Declaration where, after the year 2000s, where countries were supposed to spend at least 1% of their GDP on health. Never really happened, but it's always there. It's always been referenced. Countries are always being called out for not really doing this. Is there anything for which you can call out a country for not doing enough of One Health or utilizing enough of a One Health approach? I think we're at a place where we can begin to pull out the One Health stick and call governments to task on it. How many will actually operationalize, I do not know, but presently very low appetite, and we really call for some high-level constraints to force governments to do this kind of thing.
Je pense qu'on est arrivé à 1 heure. Donc, à moins qu'il y ait des questions pressantes, je pense qu'on va clore ce séminaire et je remercie encore énormément John et Andrea pour leur temps parce que je sais qu'ils sont hyper occupés. Donc, merci d'avoir pris un peu de temps pour nous présenter tout le travail que vous faites depuis de nombreuses années sur la Une seule santé. C'est vraiment très apprécié. Et puis, c'est d'autant plus apprécié pour quelqu'un comme moi qui est quand même vétérinaire de formation de voir des gens avec des diplômes de médecins qui s'intéressent et qui poussent cet agenda-là, ce qui n'est pas commun. Donc, vous êtes vraiment exceptionnel et merci beaucoup pour tout ce que vous faites pour la santé de tous, finalement. Puis merci de m'inclure dans vos initiatives. Alors, merci beaucoup. Peut-être qu'on peut vous garder juste quelques minutes à la fin, là, puis, mais pour tout le monde, la session est close. Merci beaucoup.
Merci beaucoup à tout le monde.
Merci.